All right, lovely people, I am back again with another masterpiece. This one is on a day in the life of an internal medicine resident on teaching service or hospital service, as some of you may refer to us. Well, you know what already goes on in the apartment. If you missed my previous video, check it out in the link above or the description box below. Anyways, we gotta get to work. After a sick patient has been evaluated in the emergency room and has been deemed medically unstable despite treatment, we get called for an admission. We evaluate the patient and treat accordingly using evidence-based medicine. Of course, cases are discussed with attending physicians who get to make corrections to the plan if any is needed. Your ability to manage a patient in a hospital is evaluated on a timely basis, so we keep ourselves providing exceptional service to our patients daily. Well, time check, 5:31. I like coming in early as possible to get a head start, but I'm supposed to be there about 6 a.m. Security checks all the way to the resident lounge. And we do get free scrubs in case you need it. I like to wear my own scrubs, but I don't know when it will be stained by blood, puke, urine. Anyways, we have the 9 team, usually made up of 2 interns and 1 second year during most of the weeknights. The number changes on the weekends. While I get report or sign out, as we call it, from my peer, the interns also get sign out from their colleagues. During the night, the team is responsible for every patient on the census. You're also responsible for admissions coming through the emergency department. Not forgetting, most night we also respond to rapid responses on the floor and code blues in the hospital. I'll discuss rapid response later on. Your main goal at night is to ensure you keep each patient under your care alive until the day team shows up. The shift is 6 p.m. to 6 a.m. If it's a slow night, you can rest your eyes a bit, or study, or catch up on your favorite TV shows while getting a massage in the resident wellness-sponsored massage chair. Currently, we have 3 teaching service teams: Team A, Team B, Team C. Team A and B are with the private attendant group, and Team C is with the hospitaler service. On this rotation, I'm on Team A. Each team has a senior and 2 interns. Sometimes we have medical students on the clinical rotation in the hospital who round with us. We are also fortunate to have pharmacy residents who also round with us on the floors from time to time. So currently, I'm getting a report from my colleague, Dr.Choe. And teaching service shift is usually 12 hours a day, 6 days a week. Yep. We only get 1 day off. After getting a report, I print my list, sign out one of the tablets, and get to see the critical patients or the new ones my team will be caring for the day. At this point in time, let me introduce my team for the day. So we have Dr. Choe and Dr. Pellegrino. And you already know who this guy is. So at 7 a.m., we have morning report. I discussed that in my previous video. Again, if you've not watched it, please check it out. So Thursdays are for pulmonary critical care cases and topics. So morning report is open to internal medicine residents, transitional year residents, and medical students. So for this morning, Dr. Marine is in the ICU, so she's holding it down. And we have one of the Palm Crate attendants discussing a unique case in the ICU. So rounding on the floors begin after 8 a.m. and it can go on until 11:30 a.m. Depending on how many patients are on the census and also the things that need to be discussed during rounds. So interns present the cases with their respective plan. The attendant gets to ask questions and teach the team on topics with regards to disease processes at hand. After rounds, we get together, go over the orders and plan for each patient with the team. We return nursing pages. If intern need anything, they ask and we figure it out together. So back in the lounge, I go over orders again to ensure the right orders have been entered. I also go over labs that I missed prior to rounding early on in the morning. We work on expediting discharges by involving members of the medical team, like case management. Being a second year, you have a lot of responsibilities. Even though you're not doing a lot of clerical work, meaning typing up notes, any decision that your intern makes is on you. So I like to give the opportunity to my interns to ask me any questions in case they have them before they decide on doing something. So noon conference is at 12 p.m., which is also the time for lunch. So we go to the recovery room, which is the cafeteria, get food and head to the conference room. Mostly the conferences are in the basement. The best part about lunch is that it's free. You know me, I love to eat. So we sit through the lectures. Like I said earlier, today's Thursday, so everything pulmonary. And in today's lecture, we are learning non-invasive forms of ventilation. So after we are done with lectures, we go back to the resident lounge and continue working on notes, calling families, with updates and also getting the discharge process going. We respond to overhead pages like rapid response, like codes. We got paged for a code blue. By the time we got there, the patient had already been resuscitated and the cardiologist was continuing the intervention that was being performed. However, we got called again for a rapid response, of which Dr.Choe will be telling us a little bit about the case.
Rapid response was called on the patient who was admitted overnight for possible UTI. When we got there, the patient had tachycardia, heart rate was up to 150. The first thing we did was EKG and check the rest of the vitals. We found out that patient was having sinus tachycardia. Blood pressure was very low, about 80s over 50s. The vitals were telling us that patient is probably in the septic shock stage. Next thing we did was to check the rectal temperature, and it turned out to be 103 Fahrenheit. At that point, we decided to fluid resuscitate the patient to improve his blood pressure, and we drew new set of blood work, including CBC, CMP, and also lactic acid. We also repeat all the cultures, blood culture, urine culture, to see if the patient is bacteremic. Even after the 1 liter fluid bolus, patient's blood pressure was still low. We ended up hanging pressor and called ICU for admission, and patient ended up getting transferred to ICU for further management.
So a simple way to explain rapid response is this way. So imagine a patient has been admitted who initially presented with persistent fevers at home and weakness. Patient, after being worked up, was found to have something called endocarditis, which are lesions on the heart valve, and it can get complicated. A family member sees the patient not speaking right. The nurse comes in, examines the patient, and also sees that patient has maybe one-sided weakness, what we call focal weakness, and a rapid response can be called overhead. So then the rapid response team presents to the room, and then the team figures out what exactly went wrong. So in this case, with patient having endocarditis, the likelihood of person having a stroke is high. So then the stroke team is called and the process continues until we get to the end of the case. Sometimes the rapid response may turn into a code blue, certified in ACLS, where we can run the code and hoping that the patient will be resuscitated. Code status can either be a full code, meaning I can do CPR and I can intubate, or it can be a DNR, DNI, meaning I do not do those interventions. If you're a DNR, DNI, that does not mean I do not treat you. I treat every patient the same, irrespective of race, gender, or socioeconomic status. So the back and forth continues until 6 p.m. Dr. Al is back, so she got some sleep, she's revived, she's ready for another 12-hour shift. So I sign out to her the new patients that I got from the ER, those that need notes written on, and those that I've not seen yet. I also tell her the critical patients that they need to watch out for the night. I usually like to discuss with the night team on the patients that they admitted overnight, whether their interventions were regarded as the right way or they did things the wrong way. We are all learning, and that's time where we can learn and improve. So after the sign out is done, my day ends. Just look at this guy. I guess this is the walk off a successful day, Yep, he's gonna wave at everybody. That's a guy, very friendly guy, and he has a bright future. Well, so I head out, and as you saw before I came in the hospital, it was dark outside, and by the time I get out, it's still dark. Yep, that's the life of an internal medicine resident on the hospital rotation. So I embark on my 45-minute drive home. Sometimes I just tickle my eardrums too much by playing very loud music just to keep myself awake. Sometimes I get to call my wife and at least we talk and see how her day went. She see how my day went. Becoming a doctor is a prestigious endeavor, and for everyone who wishes to become one, I encourage you to keep working at it. You will not regret that decision. It's a long journey and requires a lot of sacrifices. However, it's a rewarding field to be part of. So believe in yourself, stay focused, stay hungry, and keep working on your craft. In God's own time, the mantle will be placed in your hands and success will be imminent. Until then, stay positive, be encouraged, you can make it. I'll see you in my next video. Shalom.